Shishir?
Sir. I'll
Yes,
start.
we can start. Yes. Okay.
Good morning, everybody. Today, the topic for seminar is retinal detachment.
Not working? Shishir? Hello?
Hello, sir.
Yeah. Yeah. PowerPoint is not working?
Sir, now are you able to hear, sir?
Yes, yes. Now it's clear.
Oh. So, retinal detachment refers to separation of neurosensory layer of retina from pigment epithelial layer to which it is normally loosely attached. Next to CRAO and chemical burns to the eye, retinal detachment is one of the most critical eye emergencies which are encountered in ophthalmic practice. So there are four main types of retinal detachments. Those are Rhegmatogenous retinal detachment, fractional retinal detachment, exudative and combined Rhegmatogenous and exudative detachment. So coming to Rhegmatogenous retinal detachment, in general population, RRD occurs in about 12 out of 1 lakh people, that is 0.01% annual risk with a lifetime risk of 0.6%. It roughly equates to an annual incidence of about one retinal detachment per 10,000 population. Retinal detachment is relatively frequent in people of Jewish ethnicity and relatively low in persons of African descent. So peak occurrence is between 40 to 70 years of age. So heredity, though most cases are sporadic, a positive family history of retinal detachment is relevant risk factor. Because of hereditary nature of high myopia and associated degenerative retinal changes like lattice degeneration, which are important predisposing factors for retinal detachment. So risk of bilateral detachment is 15% in adults and 22% below 18 years of age. So younger the age, there is more risk of bilateral detachment. Now pathophysiology of retinal detachment. So first of all, we need to understand why the retina is attached. That is fluid pressure, hydrostatic and osmotic pressure. So majority of the aqueous leaves the eye through anterior route, and posterior route is limited by resistance from retina and RPE. And vitreous gel may function by mechanical support as well as by preventing fluid from entering the subretinal space. And mechanical interdigitation. RP microvilli wrap closely around the photoreceptor outer segments and interphotoreceptor matrix. So it is an organized subretinal extracellular compartment, predominantly comprises extracellular ensheathing domains found around the cone receptors preferentially. Uh, so it is present in the entire subretinal space. This insoluble matrix helps, perhaps serves as biological viscous glue. So it is made up of proteoglycans, chondroitin sulfate, etc. RP cellular components like microtubules and microfilaments may also contribute for its attachment. And metabolic factors by affecting subretinal fluid transport by retinal pigment epithelium and the membrane system. So once these forces of attachment are overwhelmed, a retinal detachment can occur. And in Rhegmatogenous retinal detachment, there are prerequisites, that is liquefaction of the vitreous fractional forces that produce retinal break, and a retinal break through which fluid gain access into subretinal spaces. So if only retinal break is present, but if the vitreous is not liquefied, then rhegmatogenous retinal detachment won't occur. So there has to be liquefaction of vitreous also. Then coming to predisposing factors of RD, that is presence of posterior vitreous detachment, high myopia, and history of ocular surgery, history of trauma, and predisposing retinal lesions. So whether it is like breaks, holes, tears, and dialysis. So these are the images showing retinal breaks. So coming to peripheral retinal degenerations. So lesions with moderate to high risk of retinal detachments are lattice degeneration, snail track degeneration, and degenerative retinoschisis. And with low risk of RDs, cystic retinal tufts and zonular traction tufts. Then meridional folds and enclosed oral base. So these are oral base extending to the pars plana epithelium. So those are called as enclosed oral base, and the posterior edge of this oral base, there might be retinal hole or tear. So these are the images showing lattice degeneration. There are few benign lesions with no retinal detachment. Chorioretinal degeneration near to the ora, senile reticular pigmentary degeneration, and paving stone degeneration, pars plana cysts, microcystoid degeneration, oral pearls, white with pressure and without pressure, congenital hypertrophy of retinal pigment epithelium, equatorial descent. So as far as rhegmatogenous retinal detachments are concerned, these lesions we need not worry about. So again, this is lattice degeneration with hole in the inferior part. So this is tear, which is also called as horseshoe tear, and this apex of this tear will be pointing towards the disc. Now coming to clinical features of rhegmatogenous retinal detachment. Symptoms, patient often gives a history suggestive of occurrence of acute PVD, such as flashes of light, also called as photopsia, and a shower of floaters. Floaters are due to release of pigment, retinal pigment epithelium cells and RBCs from retinal break, and multiple lines floating in the visual field before visual impairment starts. Then retinal detachment may manifest as shadow or curtain in the peripheral field of vision, which can spread to involve the entire visual field over few hours to days. So vision loss may be filmy, cloudy, irregular, or curtain-like. So field defect is very specific for locating the site of onset of detachment and thereby the site of primary retinal break. So if temporal field is first affected, then we have to that nasal part. Field defects then posterior pole RDs can for retinal detachment can be long-standing condition that progresses without symptoms until it reaches fovea. Then these are the images of fresh retinal detachment, and the inferior one is macular hole with surrounding subretinal fluid. Others are peripheral retinal detachment. So signs, visual acuity can range from 6:6 to absent light perception. So 6:6 it occurs in peripheral RDs which are not involving macular region. So it can go up to absent light perception also, such as in case of old total retinal detachment. So visual acuity is not a fit criteria to tell whether detachment is present or not. So there can be 6 vision in the presence of RD also. And a total retinal detachment will often produce whitish gray reflex on retinoscopy instead of normal orange-red reflex. Cornea is usually clear. Descemet's folds may be seen if hypotony is significant, or there can be signs of previous trauma or anterior uveitis, such as keratic precipitate. So many cases have mild anterior uveitis with relative hypotony compared to fellow eye. So hypotony is because because it is associated with mild uveitis, ciliary body detachment, as well as increased uveoscleral drainage of aqueous through the retinal breaks. And in detached retina, RP function is increased so that it will pump out the whatever excess fluid is there in. It will try to pump out the excess of fluid which is present in subretinal space. So that may also cause hypotony. And rarely the eye may show increased IOP. So it is also called as Schwartz-Matslow syndrome. So it is secondary due to blockade of trabecular meshwork with photoreceptor outer segments and inflammatory cells. So in an RD with inflammatory cells and retinal break, which is usually present near ora serrata, and with elevated IOP, we can suspect this Schwartz-Matslow syndrome. These three are the important signs to diagnose that syndrome. And afferent pupillary defect is often detected, and presence of pigment, that is tobacco dust in anterior vitreous. It's also known as Schaffer's sign. It is pathognomic of retinal tear, and it is seen in 70% of cases in phakic patients with no previous eye disease or surgery or trauma. Now coming to fundus examination, indirect ophthalmoscopy is the definitive means of diagnosing an RD, and it is aided by scleral depression to visualize the anterior retina and definitively identify the location of retinal break. So obvious detachment is observed as marked elevation of retina, which appears gray with dark blood vessels that may lie in folds, and there is loss of underlying choroidal details. So the detached retina may undulate and appear out of focus. So shallow detachments are much more difficult to detect. So suspected area of detachment, we have to always compare with an adjacent normal quadrant, especially using slit lamp biomicroscopy with 90D lens to detect any change in retinal transparency and elevations. So blood vessel contour also we can trace. So if there is any elevation, we can suspect there might be detachment. Then binocular vision is required for proper visualization. And a long-standing chronic detachment is characterized by presence of immobile thin atrophic retina with presence of intraretinal cyst and multiple pigmented and non-pigmented demarcation lines and presence of PVR. So these features differentiates from fresh RD. So fresh RD is mobile and there are corrugation and there is no retinal atrophy. So generally fresh RD we tell when the onset of detachment is less than 3 months. Classified as old retinal detachment. And a spontaneously settled retinal detachment shows pigmentary retinal degeneration with subretinal bands. So these are the images of long-standing retinal detachment. You can see there are a few cavities and demarcation lines which are seen here. So this is chronic RD, which is showing subretinal bands. These whitish structures are subretinal bands. So coming to proliferative vitreoretinopathy, it is one of the most common complications of retinal detachment. So occurring in 10% of cases. So it is a intravitreal, epiretinal or subretinal proliferation of retinal pigment epithelial cells, glial cells and inflammatory cells. So inflammatory cells mainly macrophages. So it is causing, it will cause traction because these cells have contractile properties. So once they proliferate into these areas, it will cause traction and chances of redetachment or failure of surgery is high if if an eye develops proliferative vitreoretinopathy changes. So it is also the most common cause of failure of RD surgery. It can also occur in untreated eyes or occur after pneumatic retinopathy, cryotherapy, laser retinopathy, scleral buckling, or vitrectomy. So in eyes developing PVR changes, one or more of the following risk factors may be found. That is large or multiple retinal breaks or giant retinal tears, then vitreous hemorrhage associated with the retinal break. Because with vitreous hemorrhage, again, there will be some amount of inflammation which will contribute to proliferation of those cells. And then uveitis or trauma associated with retinal break, excessive cryopexy, retinal reattachment surgery, preoperative choroidal detachment. So coming to differential diagnosis, so secondary retinal detachment, exudative or fractional, and degenerative retinoschisis, then choroidal detachment, then vascularized vitreous membranes, and old organized vitreous hemorrhage. So coming to management of
go back to previous slide. Highlight the choroidal detachment, how it is different from RD.
Sir, mainly B scan is used to differentiate between choroidal detachment and RD. So in serous choroidal detachment, usually there will be very severe hypotony. So pressure may be around like 3 or 4, 3 to 4, 5. And then choroidal detachment will find that M spike. So that corresponds to the spike of retina also and underlying detached choroid also. And choroidal detachment, there is very less to know after movements, whereas retinal detachment, there is after movement. And these are
yes, okay. Go ahead with them.
So management is, so general plan is to identify the causative retinal breaks and select the surgical procedure to reattach the retina with the least morbidity, and evaluation of fellow eye to plan for any prophylaxis, and medical evaluation for pre-surgical fitness. So identification of breaks. So there is possibility of one break in about 50% of retinal detachment, and 2 breaks in 30%, and 3 or more breaks in 20% of the cases. So there is Linkoff rules which are based on the presumption that the position of retinal break can be deduced from the shape of detachment, because subretinal fluid collects in a predictable manner from the break of origin. So by seeing the area and extent of subretinal fluid, we can assume the break to be present at certain locations. So the growth and eventual shape of retinal detachment is governed by position of the retinal break. The effect of gravity on subretinal fluid in relation to the erect posture and the anatomical limits, such as disc, ora serrata, and chorioretinal adhesions that might be present. The most superior break in detachment with multiple breaks is designated the primary break, because it will produce the same contour if it were single break. So in cases of multiple breaks, to find out the primary break, the break which is situated more superiorly can be termed as primary break. So here are the Linkoff rules. So in case of inferior retinal detachment with equal height in both the halves, so break is present at 6 o'clock. Then in inferior RD with asymmetrical height, break is present on the side with higher fluid level. So in superior RD crossing the midline, break is within 1.5 clock hours of 12 o'clock towards the side with lower edge. So in RD with asymmetrical superior detachment, so only nasal part is detached. So not crossing the vertical meridian, break is within 11.5 to 2 o'clock hours of the superior edge of the detachment. Then in inferior retinal detachment with no inferior break, Then superior break may be present with shallow peripheral trough. So here in inferior detachment, it is crossing the horizontal midline. The previous inferior detachment, it was not crossing the midline. So we were assuming the break to be at 6 o'clock position. Here it is little bit extending above the midline. And in inferior,
Go back to the number 5. I think Dr. Ankush can tell you. I think maybe 2-3 weeks back we operated one case of detachment with macular hole, and this was the
yes.
configuration. So I think Dr. Ankush was confused, like there is a superior break, but there is an inferior RD. So it is not a causative break, but it is the causative break as per the link of rule.
Yes, sir. Yes.
So inferior bullous RD break usually is superior above the horizontal meridian. So in case of bullous total retinal detachments, break is usually between 11 o'clock to 1 o'clock hour in cases of total RD. Then now posterior pole RD, it is usually associated with the macular hole. So if RD is having this demarcation line, so break might be present in the concavity of the demarcation line. So coming to management, so selection of surgical procedure to reattach the retina with least morbidity. So scleral buckling is done. It is minimally invasive and classical surgery. Generally, it is done in phakic and young patients because PVD induction can be difficult in young patients, and with vitrectomy, the risk of cataract formation is also high. So it is preferred in young patients. And vitrectomy, it is nowadays sutureless vitrectomy is being done with using gas or silicone oil as per how many days of tamponade we need, and it can be combined with encircling silicone band. Then pneumoretinopexy. So generally, pneumoretinopexy, we inject expansile gases. So it is most commonly indicated in superior breaks. Superior break, usually there should be a single break located superiorly, because after we inject the gas, due to buoyancy, gas will go superiorly, and strict positioning is required so that the injected gas will lie exactly opposite to the break, so that uh, perfect tamponade is provided. So single break located superiorly with no other intraocular complication noted are the good candidates for undergoing pneumoretinopexy. So the basic aims of all surgical techniques are to find and close all the retinal breaks permanently with either cryotherapy or laser, and oppose the pigment epithelial layer to neurosensory retina, either by indenting the sclera in scleral buckling or by pushing the neurosensory retina towards pigment epithelium, endotamponade, in pneumoretinopexy or vitrectomy. So we have to relieve all the vitreoretinal traction by achieving scleral band or a localized scleral buckle, and if needed, by vitreous surgery. So endotamponade by long-acting gas such as C3F8 is needed till the retinopexy is matured, that is 2 to 3 weeks. And silicone oil is used when longer tamponade is required. Uh, so, uh, so comparing scleral buckling with pars plana vitrectomy, in scleral buckling versus pars plana vitrectomy with SF6 in Rhegmatogenous RD of medium complexity. So concluded that similar anatomic attachment rates in both the groups, and PPV is better in pseudophakic RD, and scleral buckling is better in phakic RD. And comparing pseudophakic and aphakic retinal detachment study, both are having comparable result, and no statistically significant difference in anatomical success and complication. So choice depends on patient's compliance, cost of surgery, and experience and capability of surgeon. Then PPV without scleral buckling versus conventional scleral buckling in pseudophakic primary retinal detachment. So here also similar attachment rate with primary attachment of 76% in PPV and 84% in scleral buckling. Final is having 100% in both. And anatomical and functional outcomes of scleral buckling surgery with that of PPV in the treatment of primary RRD. So here also final reattachment rate and visual acuity is similar for both. So PPV is having slight advantage over scleral buckling here. So now comparison of various surgical techniques used in repair of retinal detachment. So scleral buckling, so reattachment rate is 94%. So complications are infection, buccal extrusion, ocular motility disturbances, and there might also be diplopia. And benefits are excellent long-term anatomical success and good visual outcomes. So coming to pars plana vitrectomy, so primary success rate is 71 to 92%. So limitations are iatrogenic retinal breaks, PVR, lens trauma, cataract progression, and more invasive procedure it is. So benefits are we can visualize all the breaks by intraoperative indentation also, and removal of opacity is sine K, and anatomical success in complicated detachment. So if patient is having cataract along with retinal detachment, it is better to manage it with pars plana vitrectomy because we are doing cataract surgery and then followed by vitrectomy. So we will have good visualization in cataractous patients. And coming to pneumatic retinopathy, it is having 64% of success rate in primary thing and primary, and 91% in final success rate. So use is limited to uncomplicated rhegmatogenous retinal detachment with superior breaks. So it is in-office procedure. There is no need for patient to get admission, and minimally invasive, reduced recovery time, and better post-operative visual acuity. But the thing is, patient should maintain the correct post-operative position so that any break present should be located to the upper part. So in that position, patient has to maintain post-operatively, or else this surgical purpose won't be served. So in patients who are like very old, who cannot maintain specific positions, better to avoid retinopexy and choose some other management. So here treatment guidelines for retinal breaks. So horseshoe tear symptomatic. So we have to treat in all the cases, that is high myopic or phakic, or even the fellow eye has to be treated with laser. Horseshoe tear asymptomatic, we can observe in phakic, and in high myopia and fellow eye, we can treat, and operculated symptomatic tears. We have to treat in high myopia and fellow eyes, and then lattice without holes we can observe, and the lattice with round holes also can be observed. So these are few of landmark studies. So first attempted RD repair was done by James Ware, and successful RD repair was done by Jules Gonin, and binocular indirect ophthalmoscope was Charles Kippens, and scleral buckling also was done by Charles Kippens, and introduction of silicone oil was done by Paul Sibis, and expansion gases was done by Edward Norton, and pneumoretinopexy was done by Hilton and Gizzard, and perfluorocarbon liquids was done by Stanley Chang, and 25 gauge sutureless vitrectomy was done by Eugene, and 23 gauge sutureless vitrectomy was done by Klaus. So coming to tractional retinal detachment. So it is separation of neurosensory retina from retinal pigment epithelium due to traction caused by proliferative membranes present over retinal surface or vitreous. So causes can be divided into adult cause and pediatric cause. So it's most common indication for vitrectomy, diabetic TRD. So in adults, first and foremost is proliferative diabetic retinopathy, retinal vein occlusions, and retinal vasculitis, sickle cell retinopathy, proliferative vitreoretinopathy, and penetrating trauma. So in pediatric age groups, retinopathy of prematurity, familial exudative vitreoretinopathy, persistent fetal vasculature, toxoplasma retinitis, sickle cell retinopathy, and PVR. So pathogenesis, so there is progressive contraction of this fibrovascular membranes over large area of vitreoretinal adhesion. And in contrast to acute PVD in eyes with rhegmatogenous RD, PVD in diabetic eyes is gradual and frequently incomplete. So therefore, we don't see floaters or flashes of light in cases of TRD, because here PVD is usually incomplete, and it is caused by leakage of plasma constituents into vitreous gel from fibrovascular network adherent to posterior vitreous surface, owing to the strong adhesions of cortical vitreous to areas of fibrovascular proliferation. PVD is usually incomplete. In the rare event of subsequent complete PVD, the new blood vessels are avulsed and RD does not develop. So blood vessels will be unable to grow over the vitreous cavity and cause traction. So vitreoretinal traction can be tangential, which is caused by contraction of epiretinal fibrovascular membranes with puckering of retina and distortion of blood vessels. It can be anterior-posterior due to contraction of fibrovascular membranes extending from posterior retina, usually in association with major arcades to the vitreous base anteriorly. So that is anterior-posterior traction. Then there is something called bridging or trampoline. It is a result of contraction of fibrovascular membranes stretching from one part of retina to another or between vascular arcades, tending to pull the two involved points together. Then coming to symptoms, photopsia and floaters are usually absent because there is no PVD, and visual field defect usually progresses slowly and may be stable for months or even years. So if RD is located like outside the arcade in the mid-peripheral region, so and patient is having good sugar control, so it may not progress. So in that case, patient will be having relatively good vision, provided if there is no macular edema. Then signs. So this type of retinal detachment is having concave configuration and breaks are absent. Retinal mobility is severely reduced and shifting fluid is absent. And the SRF is shallower than in rhegmatogenous retinal detachment, and it rarely extends to ora serrata. The highest elevation of retina occurs at the sites of greater vitreoretinal traction. If a tractional RD develops a break, then it assumes the characteristics of rhegmatogenous RD and progresses rapidly. So RD having break as well as fibrovascular membranes will generally show the features like features of rhegmatogenous RD, such as elevation and extension of SRF till ora serrata. So in that those cases are called as combined tractional and rhegmatogenous RD. So B-scan ultrasonography shows incomplete posterior vitreous detachment and relatively immobile retina. So these are few images of tractional retinal detachment. So here we can see the fibrovascular membranes leading to TRD, and in the B-scan, the detachment shape, you can see it is concave. So treatment part of this fractional retinal detachment. So first of all, non-clearing vitreous hemorrhage is most common indication for vitrectomy, and detachment with even subhyaloid hemorrhage in the macular area, very thick subhyaloid hemorrhage. So again, it is the indication for undergoing surgery. And earlier patients with tractional retinal detachment outside the arcade, so somewhere in the mid-periphery or peripheral regions, the treatment was to just observe. If it is threatening to involve macula, or if the FVPs are very much progressing, then only they used to take for surgeries. So nowadays with sutureless vitrectomy and with improved instrumentation and reduced post-operative recovery time, so even peripheral RDs, which is having significant FVPs, are also being operated. So generally, pars plana vitrectomy is performed, and membranes are fibrovascular membranes and all are peeled. So before that also we can give intravitreal injections some 4 days to 1 week prior to the surgery to reduce the complications such as bleeding, and then we can go for surgery with vitrectomy, membrane peeling, and endo laser is done, and then silicone oil is usually injected. So the more aggressive management approach we have to choose, especially in patients who have not undergone PRP prior to developing RD, and who have not never undergone any intravitreal injection. So in those cases, the severity of the condition is very much. In those cases, aggressive management is required. So coming to exudative retinal detachment. So it is characterized by accumulation of SRF in the absence of retinal breaks or traction. So it may occur in variety of vascular, inflammatory, and neoplastic diseases involving retina, RP, and choroid, in which the fluid leaks outside the vessels and accumulates under the retina. So as long as RP is able to compensate by pumping the leaking fluid into choroidal circulation, RD does not occur. So when this mechanism is overwhelmed or functions subnormally, fluid accumulates in the subretinal space. So source of fluid can be from retinal vessels or choroidal vessels. So there are many causes. So to enumerate, some of them are choroidal tumors such as melanoma, hemangioma, metastasis. And so therefore very important to consider exudative RD is caused by a tumor until proved otherwise. And inflammation such as Harada disease and posterior scleritis. So bullous central serous chorioretinopathy, and iatrogenic causes include retinal detachment surgery and panretinal photocoagulation. Choroidal neovascularization, which may leak and give rise to extensive subretinal accumulation of fluid at posterior pole, and hypertensive choroidopathy, and which may occur in toxemia of pregnancy. It is very rare cause, and idiopathic such as uveal effusion syndrome. So symptoms, depending on the cause, both eye may be involved simultaneously, and there is no vitreoretinal traction, so no photopsia. And floaters may be present if there is associated vitritis, and field defect may develop suddenly and progress rapidly. So this retinal detachment has convex configuration as with Rhegmatogenous RD, but its surface is smooth and not corrugated. So the detached retina is very mobile, and it exhibits phenomenon of shifting fluid, uh, which is the pathognomic, in which SRF detaches the area of retina under which it accumulates. So LEOPARD spots, it consists of scattered areas of subretinal pigment clumping, may be seen after the detachment has flattened. So this is the image of exudative RD. So you can see in the topmost figure, the RD is present inferiorly, and on changing the position, it goes to superior quadrant. So this is the shifting fluid, and these are hyperpigmentary changes known as leopard spot. After this is following the resolution of exudative retinal detachment. So treatment is depend on the cause of the RD. So some cases resolve spontaneously, while others are treated with systemic corticosteroids such as Harada disease and posterior scleritis. So here the important part is to differentiate between VKH and central serous chorioretinopathy, because the treatment is exactly opposite. In CSR, we will avoid steroids, whereas in VKH, which is due to the inflammation, we have to give corticosteroids. So one has to be sure in differentiating these two diseases. And in some eyes with bullous CSR, the leak in the RP can be sealed by laser photocoagulation. So coming to combined tractional and rhegmatogenous RD. So proliferation in proliferative retinopathy may result in progressive traction and membrane contraction, leading to development of posterior retinal breaks. So the shape of retina appears convex in contrast to tractional RD, and retinal surface shows hydration lines, which are diagnostic of retinal break. So then vitrectomy combined with silicone oil tamponade is commonly indicated in these cases. Silicone oil surgeries generally show high rate of reattachment. Silicone oil also helps to reduce incidence of complications like neovascular glaucoma and phthisis in very severe cases. So to know the difference between retinal detachment and retinoschisis, so features retinal detachment is mobile, undulating with surface retinal folds and underlying choroidal pattern not clearly visible. So in retinoschisis, it is smooth, immobile, and transparent, dome-shaped elevation. So classically bilateral, located inferior temporally, and retinal tears are common. That is flap tears, operculated tears. It is rare in retinoschisis. And the reaction to photocoagulation cryopexy is absent. So white reaction is seen in the outer layer. And visual field defect. So there is relative scotoma with a sloping border. And in retinoschisis, absolute scotoma with sharp border. And scleral depression. So there is localized shallowing due to escape of fluid through the retinal break. There is mild or no change. So to summarize all the different types of retinal detachment, so in Rhegmatogenous, there is a hole and through which the liquefied vitreous enters and detaches the retina. So in tractional RD, there is fibrovascular membrane which is pulling and then detaching the retina. In exudative RD, there is extravasation of fluid either from choroid or retina. In the absence of retinal tear or vitreous traction. So this fluid will accumulate in subretinal space and then it will detach. So in Rhegmatogenous RD, convex elevation, which usually extends to ora serrata. So there are folds, especially in fresh RD, and there is presence of retinal breaks. And in old cases, there may be presence of PVR changes. In tractional RD, it is concave elevation, and you can see fibrovascular membranes. In exudative, again, it is convex elevation. Usually does not extend to ora serrata, but shifting fluid is present. And all RDs are considered as rhegmatogenous unless proved otherwise. And tractional RD, proliferative diabetic retinopathy, vascular occlusions. So in exudative RD, causes are tumors, posterior uveitis, scleritis. And the treatment is scleral buckling, pneumoretinopexy or vitrectomy in rhegmatogenous RD. In fractional RD, vitrectomy is done if macula is involved or threatened. In exudative RD, medical treatment is done to treat the underlying pathology. And this is the like clinical, like how to draw and depict different lesions in the fundus. Color coding. Thank you.
Yes, very good, Shishir. Couple of questions. Like one, if there is a peripheral shallow retinal detachment which you are suspecting, how do you confirm it that there is detachment or not?
Sir, like peripheral detachment, one is like by indentation, if we can find any like tears or breaks, sir, and the surrounding retina will be appearing flat, and this shallow RD can be little bit elevated.
Okay, so one method is visualization, but suppose it is not clear, like patient has hazy media, sometimes we have pseudophakia, non-dilating pupil, or maybe peripheral capsule is opacified. So in that case, you are not doubtful, like if there is RD or not, then
Yeah.
what can be done next?
Sir, B scan.
Yes, so B scan can also see. So you have to do multiple B scans by rotating the probe with axial as well as transverse scans. Find out particularly the area where you're feeling that there is a doubt that detachment is there. So you can find it out on B scan. And another method, still you are not sure, then another method is that you can try to laser in that area in the periphery. So if because this happens commonly with white with pressure or white without pressure lesions, initially you are confused like if there is a detachment or it's just a vitreous degeneration there. So you can also try to give laser. So laser will be taken up if retina is attached. If there is a detachment, then it will not be taken up. Okay, same thing post-op also, like under silicone oil, you are confused that if there is a shallow detachment or not. One option is to do peripheral OCT if that kind of machine is available, ultra wide field OCT, because ultrasound in silicon oil field eye may not be very accurate. So the next option is you can do either indentation or you can do laser spots on those areas to see if it is accurate. Any other question? Anyone? Okay, good presentation, Shishir. It was
Thank you.
all well covered. So in the final, I think basically last few years the scleral buckling numbers are going down. Mostly, most surgeons are preferring primary vitrectomy. Though results are similar in both the techniques. Definitely in phakic eyes and particularly younger patients, we can try for scleral buckling if the breaks are possibly can be indented by the buckle. Otherwise, we can go ahead with vitrectomy. So both have, finally the results are similar. So primary vitrectomy is preferable where you can feel that the PVD can be induced easily. But in pediatric cases, sometimes it's tough. So the primary buckling may be the first option to do. In presence of PVR, of course, we cannot do buckling. So for buckling, there are definitive indications now. So if they are there, then we can try buckling in that case. Okay, so we can finish now.
Yes.
No other questions, right? Okay. Thank you, Shishir.